For those of you who don't know me, I'm Leslie Lieberman. I'm the Senior Director of the Training and Organizational Development Department at the Health Federation of Philadelphia. And I'm here today with my colleagues Claire Reedy and Carolyn Smith-Brown. So we firmly believe that communities have the answers to the challenges they face. And we do what we do because we see these answers emerge when communities can organize around ACEs, trauma, and resilience. We also recognize the potential of cross-sector, community-based networks like yours, what we call ATR networks, to be those organizing hubs and make powerful contributions to creating the conditions where all kids and families can thrive. For years, we've been supporting the vast and growing movement of ATR networks through Mobilizing Action for Resilient Communities, or MARC. In our effort to lift up the power and potential of these networks across the country, we set out a few years ago with funding from the Robert Wood Johnson Foundation to conduct the MARC ATR Network Survey with NORC at the University of Chicago. We also had assistance from a working group comprising network leaders, researchers, and practitioners that you see listed on this slide. And of course, we had hundreds of survey responses from ATR network leaders, many of whom are in the audience today, reflecting the wisdom and experiences of communities. We're joined today by a wonderful lineup of colleagues listed on this slide to help us situate, process, and apply our survey findings. I am going to now turn it over to Meg Hargreaves. Meg is a senior fellow at NORC at the University of Chicago. Meg, I see we've been joined by our panelist, Martha Davis. So I'm glad to see you, Martha. Wonderful. So actually, without further ado, I'm going to turn it over to my very dear colleague, Martha Davis, who's a senior program officer at the Robert Wood Johnson Foundation. I'll give her a chance to take a deep breath. Because of the technical problems. But Martha has not only really been a stalwart supporter of this work, but a trusted advisor and thought partner throughout the MARC journey. Martha?
Thank you. And wouldn't you, how's my sound? Okay. Oh my goodness. You know, after 20 months, you think we get this whole thing figured out. So my apologies for being late and missing that beautiful intro, Leslie. And thanks so much to everyone for joining the webinar. And I'm really so honored to say a few words with such an esteemed panel. And I just want to start by saying I'm so impressed and really grateful to the work of the Health Federation and the MARC communities, along with the NORC team that conducted this important survey that we're going to hear about. When we first began supporting this work, it was back in 2014. We learned a great deal from the 14 MARC communities across the country that have been advancing these local strategies and state strategies to reduce and prevent adverse childhood experiences and promote resilience. And really, the MARC communities and many of you on this webinar have really been at the forefront of a national movement of organizations and communities that share a commitment to promoting resilience and addressing trauma. And since then, Health Fed and their partners have helped map this very large ecosystem of ATR networks that Leslie's referring to. So this survey really presents important findings, both about the ecosystem and the broader work of cross-sector collaborations. And like you, I'm so excited to hear this presentation. So at the Robert Wood Johnson Foundation, we and our many partners, like include all of you on this call, are working to build a culture of health. And this is really an audacious vision that is where we're focused on the complex social and economic factors that have such a powerful influence on health and well-being, not only of individuals, but of communities. And to achieve this vision, this culture of health, where everybody in America has a shot, a fair and just opportunity, we have been working really diligently to strengthen the connections between healthcare, public health, and social services, defined broadly. And so that people working together can be responsive to the many needs and goals that people and communities have, whether it's physical, social, emotional. And what we believe is that to achieve the outcomes that all of us seek, we must have multiple sectors working together, just like these ATR networks that are featured here. And you know, we've really seen, I think, in the COVID pandemic, such the stark reality and the importance of these networks. So where you have social services and public health and, let's say, education, for example, these really stand as bright spots in an otherwise pretty bleak landscape where there's been a lot of disorganization and a lot of inequitable distribution of both services and policies. So I say all this because Health Fed and the ATR networks have a lot to teach communities, we think, about what makes cross-sector collaboration possible. And I hope this isn't too much jargon, but we've come to call those systems that are really the most durable change efforts aligned systems. So there's collaboration, there's coordination, and then there's this idea of alignment. And what we've begun to see across the country is that many systems who are aligning together for health seem to share some key features. One is having a shared purpose or a shared vision of what we want to do together as a group of systems. The second is some kind of shared financing structures, and these vary across the country a great deal. The third would be some way of having shared data. And a fourth is shared governance structures. These seem to point to efforts that last beyond a particular project or an emergency or in a crisis, and that they're durable and kind of built to last over time. And I really believe that these ATR networks provide a foundation for aligned systems. Many of the efforts that you all are involved in, that NORC and Health Fed have been tracking, at least have this idea of a shared purpose. And I'm sure many of us remember the first time we heard this science, it was like all the light bulbs went off and we could see the multiple sectors that ought to be working together. So it's our hope that these ATRs and the many organizations will emerge as enduring networks that are poised to strengthen the alignment of multiple systems for health and well-being. So I'll just finish by saying two last quick things. One is I want to say that equity matters. We know this, but addressing equity in the context of both health and race is critical in the goal of aligning across sectors. And ultimately, it's critical for improving health and well-being. And finally, a note about community-driven change. I know many of you all on this call have worked really hard. You are from the community, you work with community, but we know that any community collaboration or aligned system has to work deeply and seriously with communities. Like a seat at the table is not enough. What we're talking about is really sharing power is a must. So anyway, thank you so much for the chance to say a few words. I'm so glad I got on, and I'll turn it back to Leslie, but I just want to say thanks so much to Leslie, Claire, and the team at NORC for this great work.
Thank you so much, Martha, and we are so glad you're here too. And so with that, now I am going to turn it over to Meg Hargreaves. Meg, as I said before, is a senior fellow at NORC at the University of Chicago and served as the principal investigator on this study and is going to present the survey findings. And Meg is joining us by phone, so Claire is going to be her trusted assistant with the slides. So Claire, if you want to get the slides shared, and Meg, we are ready for you. Meg, we need you to unmute.
All right, thanks very much. Looking forward to quickly giving this presentation. So I'll go directly to the agenda. I'll be providing information about the content of the survey, who was in the survey sample, how many people we contacted, some characteristics of the networks that we reached, and your goals and your technical assistance needs. But that's only a smattering of the findings that are in our final report. So I really encourage you to go to the website and find the link and read the full report. And there's a great infographic as well, I must say. Thanks to Claire and Leslie for helping with that great infographic. So let me talk about the content. As you heard already from Leslie, that this is a project between NORC and the Federation, and the goal of the project was really to learn more about the prevalence of these networks, understand their capacities, learn more about their characteristics, as well as their goals and technical assistance needs. And the purpose of this was really to help support this broader movement for creating healthy, equitable, and resilient communities. So let me talk about how we created the content of this survey. We had a series of discussions and conference calls with Claire and Leslie and a whole set of survey advisors from ATR networks who helped us determine what would be the parameters of the survey, what did we consider to be an ATR cross-sector community-based network, how were we going to define that, and then to draft and review and refine the questions that were in the survey. We also did as soon as we got the items ready, we developed the online survey using the Qualtrics platform. We programmed it, and we also conducted cognitive interviews with representatives of 6 to 8 networks to get their for them to help us refine the survey one last time so that it could be finalized. Then when we fielded the survey, we were monitoring the response rate and sending out reminders that included conducting follow-up calls if needed to help people complete the survey by phone. So let's talk about who received the survey. This was the hardest part of this project. There is no national list of every ATR network. So we worked with the foundation and with other network representatives to get lists of people who attended MARC conferences, lists of networks from national social networks such as PACE's Connections. And we did outreach to other networks to find out those that weren't already in those lists. We also created sample inclusion criteria to determine who would be considered in the final sample. So we worked hard. We recognized that we didn't reach and find every network, but it was quite an effort, and we're proud of the ones that we were able to reach. So let's talk about the inclusion criteria. We used 4. One of them was that they had to use ACEs, trauma, and resilience, preferably all 3 sets of networks in terms of frameworks or concepts or practices. They also needed to be cross-sector, community-based networks. And they needed to serve and identify a particular geographic area that they were targeting. Finally, it wasn't enough to be online, an online community. These networks also had to engage their members through in-person meetings. So let me talk about who received the survey. We originally found 327 networks. Then during the survey, we did a snowball practice where we asked networks if they knew of other networks. And then we found another set of them, 46. And so we actually reached out to and had a list of 361 networks. We started the survey in December 2019, and we finished the survey in March of 2020. Of those that got an invitation, we got a response from 273 networks, which was 75.6%. And then we checked and made sure that they met the criteria. We lost another 15 because they didn't actually have in-person meetings. And so our final set of networks in our analysis was 251 networks from 40 different states. So let me talk about who were those 251 networks, and I'll talk about some characteristics related to their inclusion in the survey and other characteristics as well. So if you look at the geographic units, there were networks from 45 states, and most of them, 45%, were representing a county-wide area. And then another 26% were looking at a larger regional area. So these weren't, they were primarily larger geographic areas that were represented by these networks. Almost half of these networks had in-person meetings on a monthly basis. and another 22% had in-person meetings more frequently, 2 or more times per month. Now, when we look at how many people were at these meetings, about half of the networks had less than 25 people in there as regular attendees in their meetings. So these weren't large networks, they weren't big consortia, they were really sort of a smaller group of less than 25 who came together regularly to talk about these issues. And when we look at who were these people who came together regularly, if we look at the network sectors, we found that 6 and 10 networks represented 5 different sectors, and we organized the sectors as education and youth development, health and healthcare, social services and basic needs. The 4th was public policy, and the 5th was justice or law enforcement and military sector. And so it's really impressive to think of how many networks actually had regular attendance from all of those sectors. And if you look at the individual sectors, you can see that some of them were in almost every network. So when we look at who were these people from these sectors and how many community members were part of these meetings, most of the networks did report that they included and had some community members in their meetings, and not just organizational representatives, but their numbers are relatively small. So regardless of the size of the network, 2/3 of the networks reported having fewer than 10 community members at their meetings. Another 21% or so had between 10 and 20 community members. So these were highly represented by organizations and less represented by individual community members. So let's go to the next slide and talk about how old these networks were. And you'll see on the left, there's just a wide distribution. Some were very young, less than 6 months. Some were over 9 years old. And you know, you venerable networks, you know which ones you are. And so we also looked at network size. And again, there was quite a variation, but half of the networks had 50 people or fewer members. So if you look at the right-hand set of bars, a quarter had less than 25 people in their network, and another quarter had between 25 and 50 people in the network. So these were, there's much more we can say about what these networks did, but one of the things we want to highlight is the importance of the use of data. And a majority of the networks reported using data for learning and improvement purposes. That was 3/4 of the networks. And 58% said they used data for strategic planning, network strategic planning. And again, almost half of the networks also reported using data to work with communities to make sense of data, to monitor population level ACEs and trauma trends, to disseminate data to external audiences, and also to inform policy or systems change. So those are, I'm very impressed to see how much use the networks, given their size in their communities, were able to use data for so many purposes. So let's go to staffing. They monthly meetings. They had so much they were doing with so little staff. So when you look at the staffing, 41% of the networks reported having no full-time or part-time staff. In fact, they were more likely to operate on a volunteer basis with absolutely no paid staff than to have one or more paid staff. And so, so much was done with very few staff resources. When you look at the finances, it makes sense because the 53% of the networks had an annual budget of $25,000 or less. So they were doing all this work. You're doing all this work on a very small budget. And about half the networks actually reported having no budget, or 31%, or having less than 25, which was 21%. So imagine all the work that you've been doing on a very, very limited resources. One of the ways you were able to do this was through all the in-kind resources, volunteers, space, materials. Those are the kinds of in-kind resources that 80% of the networks used to support their activities. Only half had a grant from either a public source or a private foundation, and even fewer had other sources of income. So let's talk about the goals of these networks and all the work that you were seeking to do with your members, with your staff, and with your funding. We looked at 4 major kinds of goals that you identified. And the first one is capacity building goals. So a quarter of the networks focused on developing your network's capacity to carry out your work, including building your membership, creating and improving your network's leadership, staffing and infrastructure, and securing enough funding to just keep going to sustain and expand your network operations. Half of the networks identified goals related to strategic objectives, or that were related to specific network activities. And these activities were about convening major events, or providing education, training, and professional development opportunities, or creating online platforms for the members. About 40% identified building awareness as a network priority, in terms of developing a common language around ACEs, shared messaging around ATR topics, and engaging with community leaders, parents, and youth, and others. A quarter of the networks sought to make changes in their own members' organizations, including developing a qualified ATR workforce, using ATR evidence-based program models, and also helping staff to improve their self-care and adopt ATR attitudes and behaviors and habits, both at home and at work. The third area is about cross-sector change, and a third of the networks identified goals for coordinating action across local organizations and service sectors. That included creating a ATR coordinated continuum of care, creating cross-sector partnerships for collective impact, and also the kind of work that Martha mentioned, which is making connections among local, state, and national networks, so creating a network of networks. Now, a smaller number, only 16%, identify goals of advocating for specific policies or systems change, such as increasing access and availability and affordability of ATR-related programs, and making changes to reduce the duplication and the fragmentation of ATR services in their communities. About the same number, about 15%, focused on community-level change. And this is about supporting neighborhood-level healing, or trust, or building healthy relationships in communities, increasing community connections for families, and increasing community capacity for self-healing and resilience. Long-term networks had identified, 6% identified outcomes for children, including building a safe and nurturing environment with positive relationships and experience and other protective factors, or creating children's readiness for kindergarten and overall school success, or specific behaviors such as increasing child self-regulation and resilience. About 10% of the networks also sought to improve outcomes for families, including creating 2-generational programs, enhancing family core competencies, and increasing parent and caregiver self-regulation and resilience. 20% also focused on population level goals, looking at the overall health and well-being of children and families in their communities, looking at the intergenerational transmission of ACEs, and looking at how ACEs relates to, and ATR topics relate to, population level mental and socio-emotional health, and individual and community level resilience. This is an impressive array of goals. Many of them are very ambitious. And so we asked the networks about what kind of technical assistance needs. And again, we looked at what kinds of technical assistance needs they needed for the 4 areas of goals that we had identified. Almost 49%, nearly half the networks identified a need to help to have a more sustainable infrastructure. They needed help and identified needing help to find funding and grant writers and development staff so that they could have more resources. They also, 40% asked for technical assistance to support a whole set of data needs, the kind of data needs that use of data that we had talked about earlier, in turn, including coordinating and streamlining the collection and reporting of local and regional data, and developing surveys and other metrics and frameworks. A few also asked for, 38%, slightly fewer, asked for communications technical assistance, creating websites or online platforms with their marketing and communications and their social media and other kinds of messaging. The third area was that they asked for assistance with particular strategic objectives. 30% asked for help with training and professional development, including how to manage training requests and logistics, and how to gain access to ATR experts, and how to spread skills across a region, how to get access to updated ATR resources and information, and how to build a larger social movement. 15% asked for TA on how to engage local partners in policy change, including frontline health workers, or how to engage with local media, local foundations and businesses on community change efforts, as well as how to use community organizing practices and how to leverage funding sources such as Medicaid. The last area in which the networks asked for technical assistance was in how to support cross-sector change. And so nearly a third of the networks, 28%, identified needs in the area of effective network leadership, governance, and management. Their needs included how to do strategic planning, how to create network leadership, how to recruit members, how to move from planning and analysis into action, and how to develop strategic visions and goals. And also importantly, how to integrate racial equity concerns into their network plans and priorities. About 10% also asked for technical assistance in how to collaborate and align their efforts with other networks to scale up and have greater impact, and to disseminate information to potential allies and audiences. These needs also included learning how to exchange best practices and learn from other networks, how to dialogue with other ATR partners, and how to get out of their own regional silos or county silos and network with state and national ATR initiatives. 16% also identified the technical assistance needs in the area of policy, systems, and community advocacy, including ATR policy development, engaging elected leaders and government policymakers, and increasing public awareness and buy-in on ATR policy issues. incorporating ATR concepts into state policies, and implementing culturally responsive strategies for changing the legislation and supporting culture change, links structural racism and other aspects of racism and trauma. So there's so much more, including an interactive way to look at the connection between technical assistance needs and goals that I invite you to look at. And I'll turn this back over to the group.
Thank you so much for that, Meg. And in the interest of time, and there weren't too many questions in the chat, but if you do have questions that you are thinking about or come up as we continue on, please put them in the Q&A and we will answer them after the webinar. So now we're going to jump right into our panel. And really, to bring this ATR network work to life, we've invited 4 people who truly are walking the ATR network walk in their communities. And they are Artie Padilla of the Fresno County Trauma and Resilience Network, Ingrid Cockhren of PACES Connection, Amanda Adams of the New Jersey Education Association, and Dave Ellis of the New Jersey Office of Resilience and the New Jersey ACES Collaborative. So we've intentionally set the panel up as dyads, each with a history of working together as a network leader and a technical assistance. And if you heard through the survey, that's one of the things we looked at is, there are a lot of technical assistance needs out there among networks. And so we wanted to share with you some ways in which leaders and TA providers have been working together. And Ingrid and Artie, let's start with you. The first dyad and of the work that you've done in and around Fresno County. So Artie, could you start with sharing for maybe a minute or so, what's at the heart of the Fresno County Trauma and Resilience Network?
Yeah, so we really launched with the purpose of shared learning and having a shared understanding from the original ACES study and then subsequent research that has come after that. So that was at the anchor of really all of our institutions and organizations, and we grew pretty quickly within the first year because we held some in-person learning conferences with local speakers. So that really anchored us in making sure that we were all in alignment with what we wanted to move forward with.
Thank you. And Ingrid, could you do the same? Share with us what's at the heart of PACES Connection?
Well, at the heart of PACES Connection, we are really trying to address all of the issues that was highlighted in the presentation around technical assistance. How are we supporting communities across the country, and we have international communities as well, when it comes to centering equity, especially racial equity, when it comes to systemic issues as opposed to where we are now is really focused on individual ACEs, and also providing support through consulting, as well as convening a space for communities to be able to share ideas, share successes, and kind of cross-pollinate.
Thank you. You heard from Megan that we talked about network goals. And as Meg shared from the survey, what we heard from networks is that those goals can range from the very concrete, like building awareness. Artie, you just talked about that, training events, for example, to really much broader North Star goals that reflect visions for what just healthy and resilient communities can look like. So Artie, could you tell us a little bit about how your network has identified its goals and how they've evolved over time?
Yeah, so we've added some structure over the last few years. We launched in 2017. With each passing year, we added more structure, developed a leadership team that helped guide what are our yearly goals, really to build that in a sense, governance. We are one of those organizations that really didn't have any budget the first few years, and we started getting some small grants to help build that structure out. So that leadership team is really the group of about 15 of us that have really every year looked at what do we want to accomplish this year, and then what are our 3 and 5 year goals moving forward as we build our ongoing growth of the network, bringing in added sectors, bringing in the resident voice, as Martha mentioned earlier about developing that resident voice and that power of elevating their voice into our decision making as well. So that's really where our structure came from.
Great, thank you. And Ingrid, before I turn back to you, just one follow-up question, Artie. Have you seen sort of any evolution in the kinds of goals that the network has had since you began? You know, have you moved? You mentioned that you started out, I think, with some awareness building. Have those goals shifted?
Yeah, well, they've certainly been refined and added some depth. So we with every year now we write an implementation plan and a logic model and really a results framework, which really helps guide what indicators are we going to measure for those goals. And with PACE's connection, they've built out a wonderful milestone survey that we're using currently that really helps guide each organization or institution of where they're at along the path of being trauma informed. So that's one example.
Great, thank you. And that's a great segue. Ingrid, so tell me about what kind of tools and resources that you recommend to help networks like Artie's with that goal setting process, with strategy development, and with monitoring and evaluation.
Yeah, so we have several tools with PACE's Connection. Some are free and some require membership in our cooperative. So I'll start with free since that's low-hanging fruit. We definitely encourage people to connect with communities that are existing in their area. So one thing about us is that we provide probably the largest network. We have about 450 communities on our site. And we also have a visual. So we have the mapping the movement, so you can go and you can see what's going on in your state. There's a map of the United States. Well, it's actually a map of the world to include our international, but you can go and say, this is particular county, this particular city, who can I contact, what speakers are in my area around which different sector and subject matter expertise. So there's that, and that's also available to anyone free, whether you're a member or not. And we also have the ability to provide some consulting through our staff around strategic planning, how to grow a movement. We use our Growing Resilient Communities model to help initiatives get started in that beginning stage when everything's kind of murky, like what am I supposed to do? How do I get people together? And so that is definitely helpful. When it gets to initiatives that are a little bit further along, like Fresno, we have a space where we are convening those who are looking to really have systemic transformation. And it's a pilot, our cooperative of communities, it's a pilot for a year. However, this year we're moving into very significant programming and content around historical trauma. How do we address the cross-section between DEI and the ACEs and PACEs movement? We are talking about trauma-informed education, definitely all sectors being at the table, and how do you bring those sectors who are not represented to the table? Another aspect is going to be our data tools. And so as a part of the cooperative of communities, you will have the ability to kind of map out what trauma-informed work looks like in your community. This is a way for you to say, well, our schools are trauma-informed, but our criminal justice system is not. It helps you to identify gaps. It also helps you to know who are the people that are doing it right and what does that look like? Because the next step after that is going to be, what are the outcomes now that you've been trauma-informed for, and I use that term very loosely, for 5 years now? What's the difference in your truancy rates? What does it look like when it comes to your school setting? What does it look like when it comes to juvenile justice? And so I think those data tools are very significant, but I think more so than that, the ability to come together and convene in a space and say, this is what I'm working on, this is what I'm struggling with. What are you guys doing on that in that part of the country? And how can we work together and cross-pollinate is probably going to be the most impactful.
Thank you so much, Ingrid and Artie. Really helpful tips and thanks for sharing a little bit of your story. I know there's a lot more, but we're gonna now move on over to Amanda and Dave to talk to us about their partnership in New Jersey. All right. And there's Dave. All right. So Amanda and Dave, you have worked together for a number of years. First with Dave, you as a consultant to Amanda as NJEA was launching its ACE trauma and resilience work. And Amanda, as you were starting a local network in New Jersey, the New Jersey ACE Task Force. And I'm wondering if the two of you can share a little bit about how and why the relationship got started, and then how your partnership has evolved over time to advance your work both in the local community and now across the state of New Jersey.
Sure. Back in 2015 or 2016, a good friend of mine, Rich Wilson, introduced me to Dave at NJEA convention. And he said, there's someone I think you really want to meet who's presenting a workshop here on a topic that I think you really want to hear. And so I went up to Dave's session and he was presenting the ACE interface curriculum, understanding trauma and becoming a self-healing community. And I am the coordinator of an initiative that sends retired teachers as consultants into schools in need of improvement that tend to be in marginalized communities. And so when I first heard Dave's presentation, all types of light bulbs went off. And we exchanged information, and then the rest is history. I invited Dave to present with Laura Porter at a NJEA Urban Education Symposium, where they presented for like probably 6 hours total between a night and a overnight and a morning, where about 200 NJEA members were participating in conversations in an open space format around what this meant to them as educators. And then he was flying back and forth from Minnesota to present to individual schools when we agreed that it made more sense to build capacity in New Jersey for other people besides himself to do these presentations. And so Dave connected us to Dr. Rob Anda, one of the principal investigators of the original ACE study, and Laura Porter, who is our expert around building self-healing communities, to train 30 people to start. So NJEA bought a license to the ACE interface curriculum, and we got those 30 people started. And Dave just stretched and pushed me to build capacity amongst that presenter cohort that has been expanding ever since. NJEA had the first cross-sector presenter cohort of about 20 people who some of whom were NJEA members and others who were not, and which just expanded our ability to get this out. So NJEA's first role, I guess, or goal in this work was awareness. It was strictly to get our members, and particularly in the communities they serve, understanding the science and the research behind understanding trauma. And
Thank you so much. Yeah, that really touches on one of the goals that we identified in the survey. Dave, can you jump in and talk a little bit about sort of the partnership from your perspective and where it's gone?
Yeah, thank you, Leslie. It's been interesting working with a union, right? It's not your normal partnership that you think about. And so getting the union to understand the importance of inviting community in and actually getting out of the way and allowing community to drive whatever was going to happen. So part of the growth was the creation of an ACEs task force that they put together. We started out with what was supposed to be about 20 people at our first meeting, turned into about 80. Word of mouth spread and people wanted to join. And so, things have progressed. And I think up until the Office of Resilience came into being in 2020, that task force was pushing and motivating pretty much everything that was happening in New Jersey. And it's not that there wasn't a lot of work happening in New Jersey, there was, but it was very fragmented. And so when the Office of Resilience came along, one of the things that we did was we basically told NJEA, you are our partner. We can't do this work without you. And now we're going to go deeper in the community. And so it became this push for systems to let go of control and to invite community in. What we're trying to figure out how to do is to create systemic resilience. When COVID hit, all of our systems failed, they fell apart, and we lost people through the cracks. And what we're trying to do now is to figure out not only how do we make our communities and individuals resilient, but how do we make our systems resilient, right? And so PACE's connection has been a very big part of that for us. You know, when the Office of Resilience came online, we started creating our own technical assistance center, which is all around awareness. So all of those goals that you had up a few moments ago are all of the goals. If you looked at the 5 core strategies under our statewide action plan, you'll find pretty much everything that you've written out there. And you know, we started with awareness because if you don't know, if you don't know better, you can't do better. And so the idea is let's give people the information, create the language, all of those pieces. But then let's bring the community together to have a conversation about what do we do in the community, right? How does community drive its own destiny? And then how do we resource that as a system? How do we resource what the community says is important rather than what we or the funders or anyone else believes is important? And so, to give you an idea, we just awarded $3 million to 3 agencies over the next 2 years for what we refer to as innovation microgrants. For the first time in the history of New Jersey, we will be able to fund agencies and individuals who have ideas on what to do deep in the community. They are not your traditional funding sources. We're not looking to fund tradition. We're looking to fund something totally radical. And so those are the types of things that the partnership between NJEA and the Office of Resilience, and I will say it's interesting because my office, everyone thinks it's a part of the Department of Children and Families. It is not. We have no state dollars that are provided to support what we do. It's we just go have fun, Leslie, and that for me, that's the bottom line of this. This isn't work. This is what I do all day, every day. And the one thing that I just want to point out is that in our conversations with, I think I heard Carolyn say something at the end about historical trauma. Mm-hmm. And one of the things that we're really, really pushing at here is to understand that there are so many things that are impacting us now that we haven't really looked at the history and what the history has done to multiple generations before we even get to adverse childhood experiences, right? And so how do we begin to look at all of those different pieces, pull them all together in one place? Still doing 2-generation work, 3-generation work if we can find it, and have a true impact on everything that we're doing.
Well, thank you both, Amanda and Dave. I know I share probably that we could listen to both of you and to Artie and Ingrid for a lot more time, but we promised an hour webinar, and we're gonna stick to our promise. And I appreciate you saying fun. I'm just going to close with just a few things. So again, thank you, Dave and Amanda. Thank you to all of our wonderful panelists today. And thank you to the audience for being here today, but really more importantly for the work you're doing in your communities to advance the ATR movement. I hope you've heard a few things today to validate the importance of ATR networks, to see their potential, and especially to know that you do not have to do this work alone. There are wonderful resources out there, many on PACE's Connection, many also on the MARC website, marc.healthfederation.org, and many more in development through Dave and others' work. Last, before we end, I do want to lift up one survey finding that Meg touched on but didn't go too deeply into, and that is the role that ATRs can, and from my perspective, really must play in policy work, because that's where we're really going to see the deep and lasting changes that we're all looking for. And only 1/3 of the network surveys reported that they currently engage in policy and advocacy activities, and fewer that it was one of their top goals. But the good news for us, we're like fun and we're optimists, is that we see that there's a lot of opportunity for growth here. And one of the contributions that we at MARC have made to that, to build ATR capacity for policy work, is our policy toolkit that we developed a couple of years ago. And you can find that along with a rich and carefully curated set of resources for you ATR networks on the MARC website. Finally, as I mentioned earlier, we'll be following up with a recording, the slides, answers to unanswered questions. We'll include links to resources that were mentioned today, and also contacts of how you can get in touch with all of today's wonderful speakers. Thank you again, and have a wonderful rest of your day.